Lovely people, happy Friday. For those of you on YouTube, you're welcome. I saved you 5 minutes of your life by not recording our hangout behind the scenes, but welcome nonetheless. Very excited for today. Today, as you all know, is for those of you who are joining live, you know that Prof. Rez's shoes are being filled by somebody else, but I think they probably feel a little bit tight on our one and only Elena, who needs no introduction. I get to co-discuss with her today. She's now in the height of intern year, and guess what she decided to do with her time off? Discuss medicine, just like any uh, anyone who would symbolize Prof. Rez. Prof. Rez was discussing a case in the middle of his golf session because he could not say no to a Grand Rounds case, as some of you know. And so I think Elena is filling in that tradition very, very well. Let me hand the mic to you, Elena, to say hello, and then we can introduce everybody else.
Hi, Ravi. Hi, everyone. It's good to see you all. I think I never get away with the feeling that of being like nervous before these sessions. Maybe we have to do it a couple of years to be like fully relaxed. Yeah, I'm super excited to be here. I feel very privileged to be surrounded by all of you and learn each and every day from everyone who is here. And very, very excited for the session.
The nerves don't go away. Um, but I think that's primarily because you care. Yeah. I think the day they go away, it's probably a day that's a little sad, you know. That impetus to like push you is always an important one, though the dose can always be a little bit tricky to get right. But I think yeah, I think by the end of the case, I think you'll have a bigger smile than the one you even have right now. But this case isn't about just me and you today, Alana. We have Eugene who's scribing in the middle of two night shifts. I'll hand the mic to you, Eugene, just to say hello.
Hey, hello everyone. My name is Eugene from Ghana. Yeah, and I'm just happy to describe today. That's it.
So cool. You say that with so much pride. It rings through your voice. Eugene from Pause, Ghana. That's really, really cool. Thank you for spending your time with us, Eugene. Really appreciate it. In a very familiar position, uh, vocalizing her thoughts today, not as a case presenter as yesterday, but today Lyra is doing the teaching points. Lyra, in the last 24 hours, what major news has crossed your desk?
Nothing much. I walked a dog today again.
Okay.
This is a very, very unusual experience for me. I'm a cat person. I'm not a dog person, definitely.
Who is this anonymous dog that you walked?
My mom's.
Oh, your mom has a dog.
Yeah.
Wow. Are there like family debates over dogs and cats, or do we just leave
Yeah.
it? Yeah.
Sure.
I'm so sorry, but I think I have to agree with your mom. But I know Prof. Rez would agree with you, so I think you have a healthy defense. What kind of dog does your mom have?
It's a black chow chow. Yes.
Ooh, cute. How old is the Chow Chow now?
Very, very young, just 2 years. And
2 years.
he's very stubborn. That's why we're not agreeing with each other.
That's so funny. Amazing. Well, thank you for hopping on today. Last but not least, we have one of our new Academy members, Zachariah. This is, I think, your third or fourth case. I appreciate you presenting today, none the least because you just hopped off a plane. But Mike, to you to say hello and tell us what's new in your life.
Hi everyone, my name is Zakaria and I'm a medical graduate from South Africa, currently doing my foundational training in Cape Town. Yeah, I just hopped off a flight from Cape Town. I came to visit my folks up in the north. So I'm on a vacation now. So yeah, I'm quite tired. I just got off a night shift as well. It's been a hectic few weeks, so at least I have some vacation time. So looking forward to that and excited for today's case.
Oh my gosh, are you guys hearing the theme? Night shift, vacation, between the love for medicine is palpable. It's incredible to be surrounded by you all. I feel a little bit of guilt having my acai after a nice, long, relaxing run. Maybe I should just go work a night shift and come back. Oh my gosh. But please, Zachary, I'll hand the mic to you and we'll jump right in.
Sure. Just wait for the whiteboard to populate. Okay, there we go. Okay, so the case I'm presenting is a case that I saw in the medical emergency department, and I'm going to present the case as if we are seeing the patient and all the findings and labs as we got them. So the chief complaint is that a 36-year-old man was rushed into our medical emergency department with sudden onset of chest pain and shortness of breath for the past hour. So we triaged him immediately, and the vitals that we got was a temperature of 38.1 degrees Celsius, heart rate of 107, blood pressure of 95/60, respiratory rate of 22, oxygen saturation of 85%, 85% on room air. A quick auscultation of the chest revealed no murmurs, decreased breath sounds on the left with bilateral crepitations, and increased resonance to percussion on the left as well. Quick ECG was taken and it revealed sinus tachycardia and no other abnormalities. And based on the brief examination that was done, an emergent chest X-ray was performed. And I'm going to show the chest X-ray now. And yeah, see the chest X-ray that was performed. So I'm going to leave it and I'm going to stop there for the first aliquot. And I'll leave the chest X-ray open for a minute to reflect.
Thank you so much, Zachariah. Yeah, Elena, what are you thinking so far?
Yeah, I hope I caught everything. Thank you so much, Zachariah, for the first aliquot. So I think what I heard is that we have a very young gentleman who presents to the ED with what seems to be hyperacute onset of chest pain and shortness of breath. And on vitals, we found that the patient is febrile. They have a tachycardia and the BP is slightly low. And they also have hypoxemia. And maybe I can start with those findings and then go on to the chest X-ray. So I think chest pain and shortness of breath really make me localize to the thoracic cavity, the heart, and the lungs. And I think there's various pathologies that could do this, I think, in this manner. And some of the things that I really think about just from a mechanistic perspective are things that are blocked. And I think we talked about this before, like a pulmonary embolism, like a coronary vessel that is blocked acutely, things that popped, like a dissection, or also I think about like a pneumothorax in this context. And then yeah, I think molecules not so much in the chest. Yeah, I think those are my two priorities at this point. I think I was a little bit surprised by the fever because most of the chest pains and shortness of breath that I see don't feature a fever. So I think this is just very interesting in this context. And seeing this tachycardia and hypotension, I'm very worried about shock. I think we're not able to call it at this point. We need to see if there's true end organ damage, which usually we find out by getting labs, by getting a lactate, by seeing how the kidneys are doing, by seeing yeah, stuff like that. And yeah, the fact that the patient is also hypoxemic really makes me label the patient as hyperacute hypoxemic respiratory failure. And I haven't thought about hypoxemic respiratory failure for some time, but I think that the things that really can cause hyperacute respiratory failure are things that are in the alveolus. So water can do that, pus can do that, which is worrisome in the context of the fever that we're seeing. And again, things that are blocking the arteries, like a pulmonary embolism. So we get like a decrease, like an increase in the dead space. So alveolus that is ventilated but not perfused, and that's how we explain the hypoxemia. But I think even without seeing the chest X-ray, I'm prioritizing that something is going on in the alveolus at this point because of the hyperacuteness that we're seeing. Yes, and then when I look at the chest X-ray, I think we don't have to like go through like a very mechanistic way of seeing this. But I think what really comes to my mind right now is I look at the heart and it doesn't seem to be like very enlarged. So I don't really have like a concern for like an underlying, for example, left ventricular hypertrophy or cardiomyopathy. And why I look at the heart as well is because I want to see if there's some kind of effusion around the heart, like a pericardial effusion, which doesn't seem to be the case here. And when I look at the lungs now, they are more wide than they should be, and they are so bilaterally, and they're just as much on the apex and on the lower side to me. And so this to me implies congestion. So we sometimes see that in like hyperacute pulmonary edema like SCAPE. But what is really worrisome here, we don't only see this sort of congestion. What we see as well is that on the left side, there seems to be quite a big space of where the visceral pleura has separated from the like outer pleura, so very concerning for a pneumothorax. And I think I would even say that there is some shifting. So if we look at the trachea, I think some shifting has been started at this point. So worried for like a tension pneumothorax, and I think I'm just gonna stop here and see what you're thinking.
I think that was an excellent explanation of your reasoning throughout, Elena, and ending with the conclusion that this person has a tension pneumothorax, and I agree with that conclusion. And I know, we have, obviously, this is just the first aliquot, so we can streamline our thinking, but I'm really curious, like, what do you think your two next moves will be for this person? What do you want to do next?
I think when I see this
Yeah.
patient, I think the first thing that like even with those vital signs, the first thing that I would do is doing a POCUS, because seeing a pneumothorax is really straightforward with POCUS. You can you don't even need the M mode. You can just like put it there, and if you see that the pleura is not attached anymore, this implies in the context of hypoxemia that we need to like insert a needle there. And you have to be like, what I learned, I haven't done it before, but I think oftentimes one is not enough, especially if there's so much air, like because it's very, very tiny. So in the acute setting, you need multiple of them, but what the patient really needs is a thoracocentesis at this point. And then of course, like just symptomatic therapy. So the patient needs oxygen. The patient has a saturation of 85. So I'm assuming that nasal cannula is not going to be enough. So I'm going to give them a mask with to start with 6 to 7 liters, and then see how they're doing. And at this point, it's very important to get an ABG to see how the patient is ventilating, to get a sense of the CO2. And if if we have a combined respiratory failure, and if anything else is going on, if the pH has taken some toll.
Awesome. Can I ask you, what is your pulse right now?
Let me check. I think it's 105.
That's not a bad pulse. Yeah, I think that the point that you're making, I think the key point is that you need to get all of this air out. And to do so, the most effective way is to put in a large bore chest tube and get it out. However, that takes time. And so nothing that you can do can replace the need for that procedure, but you don't have enough time to just do that alone. So needle decompression is probably your first step, and you may need to do multiple needle decompressions to stabilize this patient, but this is a point where you divide and conquer, where you engage in somebody focused on doing a left-sided chest tube and somebody else doing the needle decompression. All righty, I'll hand the mic to you, Zachariah. What do you have next?
Awesome discussion. So, as you said, the patient was initially decompressed with a needle, but like you said as well, we just anticipated that this was going to be the patient was going to need ongoing drainage of that space. So a permanent chest drain was inserted, and then things sort of I just want to say the tension sort of settled. In terms of further history that we could now sort of gather from the patient, so we did obviously get an arterial blood gas, which was relatively normal. And a POCUS just basically showed that there was a pneumothorax. There's different signs that you use on the POCUS, but the patient wasn't necessarily in tension physiology. So yeah, the patient was a needle was inserted immediately, and subsequently then this chest drain was inserted. So in terms of further history, the patient said that he had been unwell for a few weeks with very non-specific symptoms: fatigue, malaise, fevers, weakness. And then an hour prior to presentation, he had this chest pain that came on suddenly, and then the shortness of breath, which he said progressively worsened over the course of the hour prior to his arrival to the ED. In terms of review of systems, and I'm just going to present the positive findings, endorses a chronic cough, which he says is productive on some days with white to yellow sputum. Also endorses constitutional symptoms over the past 3 or 4 months. So he has fevers, night sweats, loss of weight, loss of appetite, no abdominal pain, no urinary, no bowel symptoms. And he didn't really mention anything. Of note, though, he mentioned that he's been feeling quite weak lately. And he's sort of just been laying in his bed for the most part on most days. In terms of his past medical history, he's HIV positive, recently diagnosed at his primary care provider, with a CD4 of around 250. The patient was antiretroviral therapy naive, and he was never initiated on treatment due to the pending opportunistic infection screen. However, the patient at this visit was extensively worked up for TB due to high prevalence in Cape Town, as you all know. And the workup was revealing with sputums for acid-fast bacilli, gene expert PCR culture, urinary lamb, all negative. Even so, he was empirically initiated on TB treatment, the usual regimen: rifampicin, isoniazid, pyrazinamide, and ethambutol, due to the chronic cough and the likely suggestive history. The patient also was diagnosed with syphilis a few months prior with an RPR titer of 256. And that was more than a month ago at the same visit to the primary care provider, and had positive treponemal antibodies. In terms of medication the patient takes chronically, the patient says he doesn't take anything chronically. However, he was then initiated on that empiric anti-tuberculosis treatment, but he said he didn't really take that treatment. In terms of social and family history, he's unemployed, single, sober habits, of note, does not use any alcohol. However, he does admit to polysubstance use, illicit substances, cannabis, cocaine, and some other drugs. He also said that he's not currently sexually active, no relevant family history, and no allergies. And I'll stop there for the second eloquent.
Wow, so rich. Thank you, Zachariah. So, Elena, what happened there for you?
Yeah, this is really a fascinating case. I think before I go to the some of the subacute symptoms that you mentioned, Zachariah, I think I just want to say that the acute shortness of breath, I think, is just very well explained by the pneumothorax. And I think it's interesting to think about what can cause such pneumothorax. And I think something that we all learned in medical school is that especially tall young men, especially smokers, can develop spontaneous pneumothoraces. I don't know if they really tend to be this big and cause tension pneumothorax. This is a knowledge gap and something that I would have to look up, but my gut is telling me that usually they're not that big and pretty benign and don't even, most of the time don't require any treatment. And some of the other things that I think about, especially in the absence of trauma, because most of the tension pneumothoraces that I recall really had some sort of trauma to the chest to enable this kind of mechanism, are emphysema. So when those bully pop, they can cause pneumothorax. Usually patients have a long-standing history of smoking and they have potentially COPD. All of this doesn't seem to be the case here. And then there are some cystic lung diseases. Many of them are, I think, genetic. And I think we can talk about this more if this seems to be relevant here. Yeah, and I think what's interesting in this patient that they're very unique in that they have a risk factor as like they have a unique risk factor because they're HIV positive. And patients with HIV, we think of them as being immunosuppressed because this virus goes into the like CD4 cells and makes them not work that well. But they not only have an increased risk for infections, but also malignancies and especially vascular disease. And the latter two that I mentioned are independent of the CD4 count. Yeah, and I think what's interesting is that from like what I just mentioned with the HIV is that the patient seems to have productive cough in a subacute manner. I think I heard that they have cough for like a couple of months. And certainly when we have patients who have productive cough, we think of infectious diseases like our typical pneumonias. And still the same pathogens are relevant in patients who have some form of immunosuppression, but we just expand our potential infectious pathogens that could cause such kind of infection in these patients. And I think we definitely move out of the typical bacterial pneumonia that we know with like strep pneumo, just simply because of the time course in this setting. So yeah, I think we can talk about more what those pathogens can be when this is going to be important. And yeah, I think the patient is not on treatment for HIV at this point. But Zakaria also mentioned that they had some TB testing, which could definitely be a cause of subacute cough, fever, and malaise that Zakaria mentioned. And in Germany or in Switzerland, where I studied and practiced, TB is not very common. So I'm not too used to those tests. But recently I did some reading, and I think what I learned is that the more disseminated, and patients with HIV are very prone to dissemination. So like miliary TB or like extra pulmonary disease, the harder it is to diagnose TB. So just because the AFB is negative, which is not a very sensitive test anyway, or because the PCR is negative, doesn't mean that the patient cannot have TB. And yeah, it seems like they started the treatment anyways. Yeah, I think I'm gonna stop here.
Yeah, I think Elena, your observation about the fever from the first aliquot, I think has now been explained. And I think the truth is, most of the time that somebody has a pneumothorax, they have a bland background from a non-inflammatory disease. But I think now you have a really subacute tail and the fever makes sense. So I think the problem that we're trying to solve is a subacute systemic syndrome that features pulmonary pleural disease. But I think we have to be a little bit careful because there's a possibility that the disease is actually not hosted in the lungs and burst into the pleura, but that the disease might have been hosted in the esophagus and burst into the pleura. And that's the only piece of advice that I would have for our problem representation, especially a left-sided pneumothorax and one that includes a little bit of fluid might represent an esophageal rupture rather than a lung disease. And especially when we know that the patient has HIV and the myriad of overlap between HIV and the esophagus. So I'm right there with you, and focused on a systemic disease and an immunocompromised patient with HIV, with TB in the background. And I think it's tempting to say this is definitely lung into pleura, and that's very likely, but the morbidity of esophageal perforation is very, very high. Practically speaking, there's a simple test to clarify everything next, and that's a CT scan with contrast. The role of contrast is to look for mediastinitis here. You might scrutinize the X-ray for more evidence of air in the mediastinum, which is what I was trying to do, and I advise you all to do that every time. Whenever you see simultaneous pneumomediastinum and pneumothorax, the esophageal causes are even more ominous. So, yeah, I'll stop there and see what Zachariah has to add.
Awesome discussion. So we move on to the examination. So vital signs, the patient was still pyrexic after stabilization, with a temperature of around 37.5 to around 38.1. Heart rate remained tachycardic between 100 and 110 beats per minute. Blood pressure improved to 110/65. Respiratory rate was still around 18 to 20, and oxygen saturation was now 92 to 94% on face mask oxygen. In terms of the general examination, the patient appeared acute and chronically unwell. Of note, the patient was very wasted with generalized muscular atrophy. Patient had conjunctival pallor, no jaundice, and the patient had some generalized lymphadenopathy of note in the axillary and cervical regions. In terms of the cardiovascular exam, the JVP wasn't raised. There was a normal apex beat. S1 or S2 were present with no murmurs. In terms of the respiratory exam, so the patient initially was in marked distress with accessory muscle use. However, after decompression and face mask oxygen settled a bit, he still had some biobasal crackles, and was still a little bit hyperresonant to percussion on the left side. And initially, as mentioned above, initially had tracheal deviation to the right, which then resolved. In terms of the abdominal exam, the patient the abdomen was undistended. There was no hepatosplenomegaly, no masses. In terms of the neurological exam, and this is where the patient's admission course took a turn. So the patient had reported that for weeks prior, he had been feeling weak and tired, which worsened on exertion. However, when we examined him, his Glasgow Coma scale was 15 out of 15. He was alert and orientated ×3. In terms of the upper limbs, power was 5 out of 5. Normal tone, normal reflexes, and generally normal to low muscle bulk. In terms of the lower limbs, on the right side, there was marked muscular atrophy with 3 out of 5 power, and that's proximally and distally. Patient was spastic with clonus on the right side and had a positive Babinski sign with upgoing planters on the right side only. In terms of the left lower limb, again, muscular atrophy, power 4 out of 5, proximally and distally, brisk reflexes, 3+, and normal to sort of increased tone. Cranial nerves were all intact, and unfortunately, we were not able to really ambulate the patient due to this weakness. In terms of the sensory exam, the patient was unsure and didn't really want to fully cooperate with the neuro exam, but we sort of elicited a sensory level, clear level at around T8 to T10. And I will stop there.
Wow, what a fascinating case, Zachariah. Can I ask you, just for time management purposes, how many aliquots do you have left?
So I have 3 aliquots.
3 aliquots. So we're halfway through. Okay, that's not too bad. Elena, there's surprise after surprise. We're starting with boom, pneumothorax. Okay, we assume the patient's healthy. Boom, HIV, TB, maybe syphilis, and now a neurological element. I imagine there's a lot that is happening in your mind, but I'm curious if you were just to focus on the neuro element, what are you mapping that exam to in terms of localization?
So I hope I heard this right, but I think what seems striking is that I think in the lower extremities there seems to be marked weakness with a background of what seems to be muscle wasting, but what is also striking is the fact that reflexes are increased, and in fact there's spasticity and positive Babinski sign. And my very tiny neuro mind remembers from med school that so the first motor neuron really is like making the second one slow down a little bit. So usually we see when there is acute myelopathy, we usually see that the reflexes can increase because the depression of the first motor neuron goes away. So I think because of this the bilateral nature, we would be talking about something very different if this would be unilateral weakness. And because of the bilaterality, I'm thinking about really myelopathy here. Yeah.
Yeah, I'm right there with you. I think that's a great localization. I think that when you have symmetric leg, when you have bilateral lower extremity involvement, there's many hypotheses that could be at play, but the most morbid one is the spinal cord, and that's further confirmed when you have upper motor neuron signs, here spasticity and the Babinski sign, both very, very suggestive that there is disease centrally. And the central disease could be, of course, in the brain or the spinal cord, but the presence of a sensory level confirms that you're dealing with a myelopathy. And whenever you're dealing with a myelopathy, the question becomes really initially, are you dealing with a compressive or non-compressive myelopathy? And that's the most morbid hypothesis to try to assess. Of course, there are many forms of myelopathy, excuse me, in patients with HIV that have to do with the virus itself, but the most important associations are secondary infections that then compress on the spinal cord. So I think if I were to sort of summarize the syndrome that we're trying to get to the bottom of, we have a pleural element that may be pulmonary or maybe esophageal in its origin, a subacute systemic wasting syndrome in a patient with HIV not on antiretrovirals who now has prominent signal towards the spinal cord. And I think we will have so much momentum towards visualizing the proposed elements of disease, the lung, the esophagus, or the spinal cord. And I think that'll be a very, very important next step. All right, Mike to you, Zachariah.
Awesome, awesome. So some early investigations that we got, in terms of the white cell count, it was 5, and the diff was 83% neutrophils, which was within normal limits. HB was 6.5 with an MCV of 85, platelets of 367, coagulation profile, INR, PTT, fibrinogen, all normal. In terms of the inflammatory markers, CRP was 19, ESR was 29, renal function and chemistry, patient had normal kidney function and electrolytes. Calcium was 1,28 and normal for our lab was 2.1 to 2.5. Phosphate and magnesium were normal. The patient's albumin was 20 and normal for our lab is between 35 and 50. Other labs that we got, HIV, his CD4, though we previously noted was 250, is now 90. Syphilis, he had a positive treponema antibody test, but the titer now was 16 and previously was 256. So this indicated that he was previously treated. Cryptococcal antigen test was negative. In terms of the ECG, interestingly enough, we got another ECG from our techs. And interestingly, at the time of this ECG, it showed sinus bradycardia at the time of recording, but no other abnormalities noted. In terms of blood cultures were repeated on 3 separate occasions from different sites. and they were all negative. Other serologies, like I mentioned, was Cryptococcus that we got, which was negative. Screen for PJP was negative. Troponins were negative. And some early imaging that we got was a CT scan of the brain and spine with contrast, and it showed no abnormalities and no fractures. And I'll stop there.
Awesome. Thank you so much. Elena, what progress have you made on the neuro element? And we can kind of loop in the systemic in a second, but since we had that imaging, what happened to you for the neurological dimension of this problem?
Yeah, I think you mentioned that it's very important that when we think that we're dealing with a myelopathy, to find out if there's something compressing from the outside or if the myelin is diseased. And a CT is very helpful to find compressive diseases, which we haven't found here, but to really see what's going on with the myelin, we need an MRI. Yeah.
Beautiful. Yeah, I'd say that the compressive hypothesis has really dropped, right? I mean, most of the time when you have compressive myelopathy, you usually have disease in the adjacent bone. As a fun exercise for you, this is probably going to come in handy, especially when you're in the ER. Can you think of a form of a compressive myelopathy that doesn't show up on a CT?
Yes, but I don't know what it's called in English.
That's okay, you can say it in
Um,
German. Just say it. People will translate.
it's when
Yeah.
like between the bones.
Yeah.
when,
Epidural hematoma, epidural abscess.
yeah.
Yeah. I learned that the sensitivity for epidural abscess in CT scan is only 20%. Very, very low. But the counter argument is most epidural abscess, especially if they've been long standing to cause atrophy, usually have adjacent osteo. Acute epidural abscesses can be isolated, but this person's got atrophy. So I think that even though we should technically say epidural abscess is not fully excluded, um, the time course that would be implicated for this myopathy, I'm secretly, without telling anybody but you all, I'm in the non-compressive category of disease. So yeah, I think we can make progress on that element, and I think, as you said, an MRI will help us figure out, is this an inflammatory myopathy? I keep saying myopathy. I'm sorry, inflammatory myelopathy or non-inflammatory myopathy, and LP will do the same. And I think that's the next step for that element. I'm curious what you made of all the other elements with the labs. What updates have occurred for you?
Yeah, I think there's a lot of going on here. I think what's really striking is the anemia in this patient, which is really deep. I think the lower limit of normal for male patients or for male people is like 14 or something like that, and the patient has a hemoglobin of 6.5. So we don't have like any stigmata of acute bleeding in this patient, and I think there's a lot of reasons why the patient could have a low hemoglobin. Would definitely want to get the substrates. I think 85 of an MCV is low, so the probability of this being iron deficiency anemia is very, very high. But yeah, definitely would want to get the other substrates too. And there's definitely, although this is a diagnosis of exclusion, some anemia of chronic inflammation going on here too. The patient is below the threshold to give erythrocytes, so the patient would probably get one erythrocyte, like not one erythrocyte, but one bag of erythrocytes.
I think that's an important clarification. Just one.
Yeah, so yeah, the other thing is the hypocalcemia. It's not something that I see very often. Yeah, I think some of the most common causes are vitamin D deficiency, which is very probable here in this patient that seems to be sarcopenic, malnourished, and not a very good place. Same goes for the albumin. I think something that I really want to make sure with an albumin that is that low is that the patient is not losing it somewhere. So like very low yield is just like looking at the urine, see if the patient has like some sort of proteinuria, and if there's any sign of like diarrhea, so protein losing enteropathy. Although very unlikely. I think the other thing that I caught was the sinus bradycardia. yeah, I think we can talk about this a little bit, but I don't know if I put too much to it right now. It's there. I think I'm gonna track it. Patients doesn't seem to be on any beta blockers. Yeah, definitely want to check electrolytes, but the ECG seems to be okay. Yeah, I think I really want to get a CT spine, MRI of the spine next, and imaging of the chest, as we talked about, and see what's going on there.
Yeah, I mean, you taught everybody how to analyze all these labs systematically, but I think your conclusion seems so underwhelming, and I'm right there with you. We already knew how frail and vulnerable this person was, cachectic, had low BMI, and these labs just reinforce that that observation is accurate, and not much more for me, honestly. And if you hadn't had the chance to see this patient before, because say the emergency room is calling you to admit them, one glance at these labs, and you should train yourself to expect what you will see. And I think that the labs and the exam just line up. And for me, they don't add any diagnostic specificity, except, of course, the idea that the patient could have nephrotic syndrome. But I think that when the probability of that is super low, based on the lack of edema, but certainly very well described in HIV. So I'm right there with you. I think we need to see this disease and see radiographically, and I think that'll help us a lot. All right, Zachariah, what do you have next?
Awesome, awesome. Amazing discussion. So in terms of further workup, we have a vitamin B12 level, which was more than 400, autoimmune and serology workups, rheumatoid factor normal, anti-GBM, ANCA, ANA, anti-double stranded, all negative. And we really wanted to proceed with an LP and CSF collection, but the patient chose not to undergo the procedure despite extensive counseling. So I'm going to pause here for this aliquot, and I suppose we can maybe just reflect. We face now with a diagnostic dilemma where we sort of need some CSF collection, further imaging, and the patient is sort of now at the point in the admission where the patient actually wanted to go home and um, sign himself out and refuse hospital treatment. So in a situation like this, what is your guys' approach to this kind of a situation? When you worry that we worry that this patient is so sick, and the patient, however, is of sound mind, and the patient has been extensively counseled, and the patient still wanted to check himself out of the hospital and leave.
Yeah, I'm really curious. What's your take, Elena? Have you bumped into this yet, or?
Yeah, I haven't really been in many situations like this. But I think you discussed a case with, I think, Maddie together a couple of weeks back, and that really struck me. And I think it's really important in those circumstances to push yourself like to the background and not make this about yourself, but like truly about the patient and what they want. I think, of course, we're going to explain to the patient what the risks are and why we want to do what we want to do, why we feel those tests might be necessary, and what solution what like findings they could bring up, and what implications that would have for the patient. Because I think it is also a patient's right to not know. We had a discussion in the Academy chat a couple of weeks back about how testing for HIV is done globally. And for example, all of my patients that I want to test for HIV, I need like informed consent. So I can't just like come around and say like, look, I did this test and now it's positive. Like now you have to deal with it. And I think it's really the patient's right to not know. As long as I have done my due diligence about telling them why I would want to do what I would want to do. Yeah.
I completely agree with you. I think I was trying to pull up some notes in my Evernote because I'm trying to formulate my thoughts with more clarity. I'm having a hard time finding it. I think the reality is that I think the most important piece of advice that I have for all of you is to make sure that you remember that you are there to serve the patient. That's it. And I think medicine installs a little bit of hubris in people going through the journey and we think that we know better. We don't. That's the most important piece of advice I have for you. Except that sometimes you may know better because you are watching a patient not make logical, linear decisions. And when you see that, as you might infer in this patient, you're like, you're not making logical, linear decisions. You have to understand why. And the why can be very, very difficult. The why could be that this person has disseminated TB in his brain and can't make decisions because he has no ability to make decisions. So you always have to know, okay, if I think the patient's not making decisions that are in keeping with what most people would make, why? And if the answer is that they have a chronic neuropsychiatric condition, then be practical. What can you do about it? And if the answer is nothing, then you can have a moral high ground, take an ethical stance, but I'll tell you what reality will be. Reality will be that the patient's decisions will be the ones that are enacted, no matter how you feel about it. That's the reality of it. If you can do something about it, then you probably should and try. And I think the worst thing in the world is to find yourself on the opposite side of the treatment table with a patient. And so what would I do in this situation? I would try to establish whether this patient was using all his brain power. And if there was a deficiency in brain power, whether I could do something to try to reverse it. But ultimately, the most important relationship, the most important thing is our relationship with the patient. And if that gets damaged, there's no hope. And so remember not to stand between you and the door. Remember that a hospital is not a jail. And remember, though, that you do have the obligation to make sure that if somebody has a problem that you can help with that is impeding their ability to make helpful decisions for them, then you should. I had a similar situation just last week, and Kara, who's sitting next to me, uh, got to hear all about it because I gave that patient my phone number, my cell phone number, and he had horrible heart failure, kept leaving the hospital, kept coming back. Ultimately, it turned out that he was leaving the hospital probably to use methamphetamine. And he didn't want to disclose that. I suspected that. But then he kept calling me and calling me, and ultimately came back to the hospital and he got better. And yeah, so the relationship was really, really key. And that's one success story. Many, many times that there's no success, and that's okay too. I just rambled, but biggest thing to remember is a hospital is not a jail and that you're not in charge. You're there to help somebody else, not tell them what to do. All right, Zachary. I don't know if that answered your question. Oh, I think you're muted, my friend.
Oh, sorry. No, it's a wonderful discussion. I think that's an aspect of medicine that we don't get to share, and it doesn't come across in the VMRs. That we are actually humans at the end of the day, and we are treating patients, and we are there to serve patients. And like you said, we are not in charge. So this patient was extensively counseled, and the patient agreed to do one or two last diagnostic tests, and that was it. So the patient agreed to an MRI with contrast, and the MRI with contrast showed leptomeningeal enhancement and nerve root enhancement seen in the lower thoracic and lumbar region. And radiology said clinical correlation is advised. And then I have a last aliquot afterwards, which will reveal the diagnosis.
Amazing, Zachary. I'm just curious to sort of help us manage. We're definitely going to reflect a lot on the neurological elements, and I am excited to hear Elena's thoughts. I just want to make sure, are we going to tuck in the respiratory elements as well, or do you? I'm just curious if you have more imaging of the chest and the esophagus, or should we just focus on neuro for this aliquot?
No, I think we can just focus on neuro, but the last aliquot will sort of reveal the respiratory component as well.
Okay, sounds good. Okay, all right, Elena. You asked for this MRI, and Zacharia's magical skills convinced the patient to get one, which is wonderful. So where are you at now?
Yeah, it's definitely a finding that I haven't seen myself before. But I think before I want to say what could be going on, I think in this patient, I'm very, very open to the possibility that there are multiple things going on, just because of the patient's background and because what seems that the patient might not have as much contact to the health system, just by the way they seem to react to healthcare helpers. So yeah, I think the leptomeningeal enhancement can be due to many things. I think infections can do that. Certainly TB and I think other like mycoses can do that, which the patient is all at risk for. I think autoimmune conditions can do that as well, which doesn't seem to be a priority here. And something that is also very worrisome in these patients is malignancies, especially liquid malignancies. I don't know if I can make much more progress here. I think without a CSF fluid and some of the testing that we can do there, I think we could think about some serological tests from the serum that we could get to test off some of the infections that can do this. And then maybe to also get a sense to do like a fax to see if there's some sort of lymphoproliferative disease going on here. Yeah, I think, yeah, we're still in this patient that seems to have this like pleuroparenchymal disease, the diffuse lymphadenopathy, very young patient, HIV positive and other like syphilis positive as well, myelopathy and this like wasting syndrome. And I think we haven't explained the lung yet at all. And the I wonder if the myelopathy overlaps with the lung findings that we might potentially find. I think if this would turn out to be TB, I think it's curious because the patient is on therapy. So to see if there's some resistance, especially to rifampicin. I think if patients are resistant to rifampicin, they often are resistant to isoniazid as well. So yeah, we're gonna see what the CT shows, I think.
Yeah, Elena, I'm right there with you. I think it's very, very difficult to make a tremendous amount of progress, but I think there's a syndrome here that I think we can study a little bit, which is that the meninges and the nerve roots are enhanced. And I think whenever you are studying the nerve root enhancement, I think there's a really important question to try to get to the bottom of, which is, are the nerve roots enhancing because they're inflamed? Or are the nerve roots enhancing because they are infiltrated? And so an example of a nerve root enhancement because of infiltration are every single granulomatous disease you can think of, like TB, like sarcoid, and like lymphoma. And what they do is there is a very active, super inflammatory lumbar puncture with a high amount of cells, low glucose, and the meningeal disease is an inflammatory, is infiltrative in nature and starts to spread down the nerve roots. In stark contrast, primary diseases where the nerve roots are inflamed, not infiltrated, include a whole list of viruses like the herpes virus. So a classic example of nerve root inflammation, not infiltration, is HSV2, Ellsberg syndrome. I think it's one of Yaz's favorite diagnoses. In patients with HIV, they can also get CMV to do the same thing. And notoriously, spirochetes love to do nerve root inflammation. And we had a case recently that I think some of you were there for, where Lyme disease did a very, very similar thing to a patient. And also syphilis. Actually, Aaron, one of the very few times Aaron Berkowitz was stumped by a case was a case of syphilitic leptomeningeal and nerve root disease. So I think for this finding, if you are saying the nerve roots are inflamed, you would think of herpes viruses and spirochetes. If you are worried the nerve roots are infiltrated, you would worry about granulomatous disease process spanning the whole spectrum of categories. And how would you make progress on those two things? Which category? As you said it already, a lumbar puncture would help you a lot. I think it's also interesting to use other things too. Most of the time, when you have infiltration affecting the nerve roots, it tends to be the whole nerve axis. So the patient's brain has leptomeningeal enhancement, they have headaches, they also have their cervical spine enhanced. So for me, even though we don't have the lumbar puncture, the fact that the enhancement is so localized to two specific regions has me moving less towards infiltrative and more towards primary inflammation, i.e. the herpes viruses and the spirochetes. And you might wonder, as a speculative hypothesis, let's do this a little bit back and forth. So his RPR titer has, I'll just say it because of the sake of time, his RPR titer has improved, but I wonder if there's a possibility he has neurosyphilis that was undertreated based on the fact that he received IM penicillin and not IV penicillin. So neurological syphilis would make a tremendous amount of sense here based on that observation. So yeah, those would be my thoughts, and I think how we overlay them with the chest is probably it's a fun exercise, but um, I think we probably are best to learn from Zachariah for the sake of time than anything else. But I do want to offer you the mic, Elena, if you want to add in any final thoughts or reflections or anything that crystallized while I was babbling away about that distinction.
Oh, that's really, really interesting. I haven't been in this space before. I wonder, I wanted to ask you if
Yeah.
what seems diffuse lymphadenopathy does anything for you in this
Really
context.
good question. In a patient with poorly controlled HIV, the value of disseminated lymphadenopathy is complicated because HIV itself can do it, especially when it's uncontrolled. And so the question is that just proof of the presence of HIV, or does that signify another process? And if you believe the latter, you would invest more heavily in a disseminated granulomatous process, doing the leptomeningeal disease for sure. So yeah, I think that is an argument potentially for a more infiltrative process as it has infiltrated the lymph nodes. But the counter argument to that hypothesis getting complete approval is that HIV itself can do the lymph nodes. That makes sense? Yeah, awesome. All right, Zachariah, the mic is yours.
Awesome, awesome, amazing discussion. So maybe a bit anticlimactic, but on admission, the patient reported that cough, and we did send off some sputums, which returned back as positive. The PCR was positive. So a multidisciplinary team with neurology and radiology together made the final diagnosis of primary respiratory tuberculosis with spontaneous pneumothorax with likely presumed TB arachnoiditis. And unfortunately, this wasn't a good outcome um, as the patient demised the next week in the ward. So the patient was quite sort of, like I said, based on the refusing of testing, the patient was referred to psychiatry for an assessment to determine whether the patient has capacity, and the patient was assessed to have capacity. And then one of the days in the ward, when the patient was in the ward, the patient had removed the drain from the pneumothorax. From the chest drain, he had disconnected the bulb. So essentially, it became like sort of like a sucking chest wound, and the patient was thought to have tension physiology and subsequently demised within the next few minutes to hours. So yeah, unfortunately, not a great outcome for the patient. And yeah, I think it was from the start. It was um, being being in the primary team providing for the patient. It was very difficult to sort of consolidate care between the family and the patient's expectations of what they wanted and what care. And there was also sort of the reason for delayed presentation, because the patient sort of was at home sick for quite a few weeks prior to presentation. The history that we got from the mom was that the patient hadn't been walking for quite a few weeks. So it's presumed that already then had dissemination of the TB, even though he had been worked up extensively for TB the months prior. Now on admission, gene experts were positive, so he had primary pulmonary TB, which then complicated with a spontaneous pneumothorax. And then with discussion with neuro and radiology, in light of the findings of the positive PCR for TB, that the leptomeningeal enhancement was most likely TB arachnoiditis. Yeah.
That's a very unfortunate case, Zakaria. I think that it seems that if you just study the big picture of this case, a 36-year-old having probably some underlying element that we never got to be able to put our finger on that led him to be in such a vulnerable position with, as you said, cocaine use, cannabis use, other substance use. And I think the underlying diagnosis is actually whatever was driving that substance use, because it's likely related to the acquisition of HIV and subsequently the diagnosis of disseminated TB and subsequently the very poor outcome related to that. And I think that's absolutely tragic. It's also just important for all of us to recognize that when we're meeting this patient at his 36th year of life, knowing that the entity and this chain of reasoning that got him here began much, 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 much longer, makes it a little bit difficult to achieve any outcome beyond a tragic one. It's very, very hard to do that. And so I think part of that is expectation setting from our end, but also to avoid frustration and anger towards the patient who was not following the advice that you would have for them, because the roots of that are very, very deep often. But Elena, there were so many elements to this case, medical, neuropsychosocial, and I'm curious, what are you stewing on, and what are your reflections?
Yeah, usually I need some time for my reflections, but I think when we see patients in hospitals, then we're with them only for a very, very short period of time. When we compare that to how much they're not with us, and to really get a sense of who is this person in front of me, and what do they want from me, and how can I help them, is maybe one of the most important things. And I think we can only do so much. Yeah, and all the other reflections come at another point. I'm very thankful for Zakaria for sharing this case, and thanks to Eugene and Yura for scribing and teaching points.
Yeah, I think that's so well said. It's so incredible how easy it is to lose sight of that with all the computers clicking and the telly and the person asking you to put this order and that order, how easy it is to lose sight of the fact that you're just there to help these people feel better. And I think it's a beautiful simplicity, and I'm glad you got to emphasize that. Lyra, the mic to you.
Yeah, thanks everyone for this amazing section. You already said everything, so since we're over the session time, I will just emphasize that it is really important to, when things get very, very complicated, to just get back to where we started. And we started with chief complaint of hyperacute chest pain. And with presence of that, we centered ourselves and our minds inside the thorax, and we're thinking primarily of the lungs in pleural problems since we had pneumothorax. And this was the main clue, I think, when we also started to have a neurologic center of gravity in this case. And it's also really important to know who your patient is, as Elena said, and know their past medical and life background. And since we learned that this patient had HIV infection in the past that was untreated, it is important to remember that those patients are prone to various infectious diseases as well as malignancies, and even with normal CD4 count. And another important point that I wanted to emphasize is that if tuberculosis, if it tends to disseminate in patients infected with HIV. And this is also important to remember that even with multiple negative testing, the more disease is generalized in the patient's organism, the harder it is for us to diagnose, and we need to keep our mind on our primarily theories and be dedicated to them. That's everything.
It's infinitely harder than you make it seem to summarize a case of this complexity that also has medical and non-medical elements. Thank you. That was absolutely outstanding. It's a real treat to share the stage with you all. I hope you all someday you'll look back, maybe when you're all attending, to what it is that you're doing as trainees. All four of you who are here today. It is uncharted territory for a first-year resident to discuss a case like this, for a practicing physician, but soon to be intern, hopefully next year, to scribe in the middle of 2 night shifts, and also for a soon to be intern to be able to capture this case like this is unbelievable. It's going to be the patients of the future are very, very lucky, and it's cool for us to bear witness to it. All right, guys, have a great rest of your day. See you later.